Welcome back to the deep dive. Today we are undertaking a really critical mission, interpreting one of the most demanding areas in all of acute care.
Trauma surgery.
Exactly. We are diving deep into Chapter 29, which covers torso and pelvic trauma. And this is from the 28th edition of Baily and Love's Short Practice of Surgery.
And we should be really clear about the goal here. This isn't just a reading of the chapter.
No, not at all. We are building conceptual anchors. We're trying to draw out the essential knowledge that you, the learner, really need to master this material.
That's it exactly. Think of this as your framework, a scaffold. So when you go to the textbook, you'll already have the major decision trees sort of mapped out in your head.
So this is a ready reckoner, a revision guide.
Yeah, but, and we have to stress this, it is absolutely not a replacement for reading the source material.
Of course.
We're just, trying to help you organize that sheer volume of facts into something actionable.
And the place Chapter 29 starts is, I think, just perfect. It immediately pivots our thinking. It takes us away from that dry anatomy we all learned and focuses us entirely on survival.
Well, it has to, because that's the foundational truth of modern trauma management. And it's really the first key you need to grasp from the text.
Which is?
The overriding importance of physiology over anatomy. I mean, for decades, the focus was so intensely on the precise anatomical diagnosis, where did the bullet go, exactly which vessel was cut. But the modern approach recognizes that the patient's whole system crashes physiologically long before we can achieve a perfect anatomical repair.
And the numbers in the book, they're just snark. They show you exactly why that pivot is so necessary. We tend to fixate on the brain, but the torso holds the most immediate threat.
Precisely. We all know brain injury is the biggest killer, right? It accounts for about 42% of trauma deaths.
Mm-hmm.
But look at the second major killer. It's major hemorrhage. And that's a massive 39% of mortality.
So almost the same.
Almost the same. And where does the vast majority of that bleeding happen? It's in the major cavities of the torso, the chest, the abdomen, and maybe most insidiously, the pelvis.
So that's why this whole idea of damage control, resuscitation, and surgery is so central. You're just trying to preserve normal function.
You're preserving physiology. That's the entire game.
So our deep dive today is really a mental shift. We're moving from, this sterile anatomical drawing board and trying to identify where the injury is.
To managing how that injury is systemically affecting the patient's stability.
It's a race against time, and stability dictates every single move you make.
And that focus means you are constantly interpreting signs of collapse rather than, say, waiting for that perfect confirmatory image. You're managing the biological systems first, just to buy the patient enough time to survive.
Okay, so let's unpack this. When an external force, blunt or penetrating, hits the torso, the injury it doesn't respect the nice, clean lines we drew in anatomy class.
No, not at all.
And the text has a great term for this problem. It talks about the surgical challenge zone.
Yeah, the junctional zones.
Junctional zones.
They're literally the surgical no man's lands. They're these critical interfaces where different anatomical regions meet, and because everything is packed so tightly in their major vessels, multiple organs, an injury that crosses one of these zones, it poses just these complex, diagnostic, and huge surgical challenges.
You have to be hypervigilant.
Hypervigilant, absolutely. The source outlines 4 major zones, and it starts with the most treacherous.
Okay.
So first, you've got the junction between the neck and the thorax, the root of the neck, basically.
Which is just a corridor of critical structures.
It's a high-risk corridor. It channels all the major vascular structures, carotids, jugulars, the great vessels, down into the chest. And getting control of bleeding here is notoriously difficult. It often requires these really complex surgical maneuvers to get proximal and distal control of a vessel.
Okay, so that's number 1. What's the second?
The second is the interface between the thorax and the upper limbs. And then the third, which is, I would argue, the most deceptive zone at all.
The diaphragm.
The junction between the thorax and the abdomen, which is defined by the diaphragm.
And it moves. That's the key, right? It's not a static floor.
It's not stationary at all. With every breath, it can move between the 4th and the 8th intercostal space.
So what that means is a wound that looks like it's high up on the chest wall can easily penetrate the abdominal cavity.
Easily. And this is where we get to one of those critical rules you just have to commit to memory.
Okay, what is that?
Any penetrating injury below the nipples, which anatomically is about the 5th intercostal space, has to be investigated as if it has entered the abdomen, period.
You just can't exclude it.
You cannot exclude an abdominal visceral injury without directly looking or getting highly sensitive imaging. If that injury tract crossed that moving floor, you have to assume there's a risk to the stomach, the liver, the spleen, until you've proven
And
otherwise.
the fourth junctional zone.
That's between the abdominopelvic structures and the groin. And this forces us to confront the really unique challenge of the pelvis.
Right. The source emphasizes that the venous and arterial plexus here is just a minefield. Controlling hemorrhage is exceptionally difficult.
And because the pelvis isn't like a major limb artery that you can just put a clamp on,
No.
it's a massive, complex network of vessels, veins, and arteries, all interwoven with these sharp bone fragments that are just causing more damage.
So when the pelvic ring fractures, those fragments are continuously disrupting the venous plexus.
Right. And this is why controlling the bleeding often requires controlling both the arterial inflow and the venous outflow, usually through external means. And this is why angioembolization, where interventional radiology goes in and plugs the bleeders, is listed as a vital adjunct, because surgical control deep in the pelvis is often just impossible.
So that's the structural challenge.
Yeah.
Let's shift to the dynamic process of collapse, the critical physiology. And we have to revisit the latest ATLS principles, the CABCDE.
Right, with that first C being for catastrophic hemorrhage control, which often overrides everything else in major trauma. You stop the life-threatening bleeding first.
And for the learner, there's a fundamental rule for locating that bleed. It's that physiological mnemonic.
The bleeding mnemonic. 1 on the floor and 4 more. It's brilliant in its simplicity.
It really focuses the mind. So 1 on the floor is obvious. That's your external visible hemorrhage.
Yep.
Where are the 4 more that can hide just massive amounts of blood?
They're the big internal cavities that can hold pints and pints of blood before any symptoms become obvious. So the chest, the abdomen, including the retroperitoneum, the pelvis, and the extremities, specifically a big, long bone fracture like the femur.
So if your patient is in shock, the blood is in 1 or probably several of those 5 locations.
That's your search pattern.
This brings us to a really crucial concept, the subtle shock. We're all taught shock means a fast pulse and low blood pressure.
Right, the classic signs.
But the source warns that in young, fit people, the typical victims of high-energy trauma, their physiological compensation is so powerful and so dangerous, they can be bleeding out silently.
I mean, the body will aggressively shunt blood away from non-essential organs to keep the brain and heart perfused. And this compensation can keep the blood pressure looking deceptively normal. The heart rate might only be a little bit elevated.
So an isolated pulse rate is just unreliable.
Completely unreliable. You'd have to look past the blood pressure cuff.
So what are the honest clinical indicators? The signs that compensation is starting to fail and the patient is internally crashing.
The most critical signs of ongoing bleeding are a rising respiratory rate tachypnea and, probably most reliably of all, a rising serum lactate.
And the respiratory rate is the body trying to compensate for the acidosis, right?
Exactly. The metabolic acidosis from poor tissue perfusion.
So why is lactate the physiological truth teller?
Because it measures the cell's desperation. When perfusion is inadequate, even if the blood pressure looks fine, the tissues switch from their efficient aerobic metabolism to this desperate, oxygen-starved anaerobic metabolism.
And the byproduct is lactic acid.
The byproduct is lactic acid. So a rising serum lactate, even with a seemingly normal blood pressure, means the patient is in global tissue hypoperfusion. They are in shock, full stop, regardless of their vitals.
This is a perfect spot to check in. Imagine a young, fit patient. High-velocity blunt trauma, their heart rate is 100, BP is 110/70. They look stable, but the mechanism is bad.
A classic scenario.
How do you detect that hidden bleed before their pressure finally tanks? Which physiological indicator we just mentioned, increasing respiratory rate, increasing pulse rate, falling BP, or rising serum lactate, is most likely to reveal that major hidden hemorrhage?
And the answer has to be the rising serum lactate or the increasing respiratory rate. If you miss that, if your brain immediately went to falling BP, you really need to rewind and listen to that section on subtle shock again.
Because in that young, compensating patient, you have to focus on the signs of poor perfusion, the lactate and physiological stress, the tachypnea, not just the blood pressure.
Absolutely.
All right, let's move into the chest. Thoracic injury is involved in over half of all trauma deaths. It's a massive killer.
It is, but the source gives us this really hopeful statistic.
Yeah, that over 80% of chest injuries can be managed non-operatively.
So the game then is swift, accurate diagnosis that immediately separates, a simple rib fracture from an immediately lethal threat.
And that diagnostic process often starts with the EFAST.
The extended focused assessment with sonography for trauma, yes.
What makes it so valuable in the chest?
Speed and focus. We're not doing a full echo. We're looking rapidly and non-invasively for the immediate killers. Cardiac tamponade, free blood or hemothorax, and free air or pneumothorax. It's purely for bedside triage. It identifies the patient who needs a chest tube or needs to be on the operating table now.
But in the grossly unstable patient, even the time for an EFAST might be a luxury you don't have.
That's when you move to the ultimate emergency intervention, the finger thoracostomy.
Which is reserved for the patient who is actively crashing.
Right. They're circling the drain, usually showing signs of a tension, pneumothorax, major hemorrhage. The physical exam is ambiguous, and there is just zero time for any imaging. It's both diagnostic and therapeutic.
So conceptually, where are we doing this?
In the safe triangle, specifically at the fifth rib, just anterior to the mid-axillary line. You make an incision, you bluntly dissect into the pleural cavity, and then you put your finger in and do a pleural sweep.
And the key point is that the risk of that invasive procedure is just completely outweighed by the certainty of death if you don't act.
That's the calculus.
Now, what about traditional imaging, the chest x-ray? The source highlights a number of diagnostic traps, especially with the common supine film.
Well, we always want an erect CXR because gravity helps you see small pneumothoraces, but the patient's often too unstable or there's a potential spinal injury, so we're stuck with the supine version. And that position can hide things.
Let's go through the 3 big pitfalls.
Okay, pitfall 1. Assuming you need an x-ray to assess for a tracheal shift. If you suspect a tension pneumothorax, you assess the trachea clinically. You feel for it right above the sternal notch. Waiting for the film is a catastrophic delay.
Okay, pitfall 2.
Pitfall 2 is failing to tell the difference between a hemothorax and a pneumothorax on that supine film. Hemothorax looks like a homogeneous cloudy opacity. A pneumothorax is radiolucent, it looks dark, and the warning from the source is crystal clear. Look carefully and do not drain the wrong side.
And the third pitfall, which really ties back to our core philosophy.
Pitfall 3. Never, ever pursue radiological investigation over resuscitation in an unstable patient. If they're crashing, they need an intervention, not picture. The CT scan, which is the gold standard for defining these injuries, is strictly reserved for the stable patient.
Okay, this sets the stage perfectly for the core of this section, the deadly dozen threats to the chest. We'll focus first on the critical 6, the immediate threats.
Right, the ones managed in the primary survey.
Let's start with the most famous mechanical killer.
Tension pneumothorax. The valve effect.
Can you just walk us through that mechanism again? Why is it so lethal?
It's a one-way valve leak. Air gets sucked into the pleural space with every breath but can't get out. This pressure collapses the lung, sure, but the real systemic disaster is the mediastinal shift.
It shoves everything over.
Everything. The heart, the great vessels, it all gets pushed to the opposite side. And that kinking dramatically decreases venous return to the heart. That's what causes the profound obstructive shock and cardiac arrest.
And the diagnosis is always clinical.
Always. You never wait for imaging. Treatment is immediate decompression, now favoring safer zones like that fifth rib in the safe triangle, or the finger thoracostomy in extremis.
Okay, next, pericardial tamponade, the compressed heart. I always think of it like a water balloon in a rigid box. The heart just gets squeezed.
Oh, it's a great analogy. And it doesn't take much. Even 50 milliliters of blood, especially if it clots, can cause severe compression because that pericardial sac is so rigid, it just prevents the heart chambers from filling with blood. Immediate mechanical failure.
And we all learn Beck's triad muffled heart sounds, hypotension, raised JVP. But what's the critical caveat in a trauma patient?
If that patient is bleeding heavily from somewhere else, say a femur fracture, they might be so hypovolemic that their neck veins are actually flat. The classic raised JVP might be absent.
So EFAST is your most reliable tool.
By far. And here's the absolutely critical distinction in management. The role of pericardiocentesis.
Have no role.
It has basically no role in traumatic tamponade. The reason is simple. The blood from a penetrating injury usually clots immediately. You can't aspirate a clot through a needle. So the treatment is immediate operative management. A thoracotomy to evacuate the clot and repair the heart directly.
Okay, number 3, the open pneumothorax. The sucking chest wound.
If the hole in the chest wall is big more than 2/3 width, the diameter of the trachea air will preferentially enter through that hole instead of the airway. The patient effectively stops breathing on that side.
And the management is so elegantly simple.
You cover the defect with an occlusive dressing taped on only 3 sides. This creates that flutter valve we mentioned. Inhalation seals it. Exhalation lets trapped air escape. And this is immediately followed by a chest drain inserted at a different site.
And the warning is,
Do not fully seal the wound until that drain is in, or you just converted an open pneumothorax into a deadly tension pneumothorax.
fourth is massive hemothorax. The indication for surgery here is all about volume.
It's purely quantitative. An initial drainage of more than 1,500 milliliters of blood, or an ongoing loss of more than 200 mils per hour for 3 to 4 hours. That tells you a major systemic vessel is hit and needs surgical repair.
And you never clamp the chest tube.
Never. You'll create a tension hemothorax and make things much, much worse.
Fifth, flail chest. So that's 3 or more ribs broken in 2 or more places.
Right. And the key clinical diagnosis in a patient who's breathing on their own is paradoxical motion. The broken segment gets sucked in during inspiration and pushed out during expiration.
But the real lethal part isn't the mechanics, it's the underlying lung injury.
It's the pulmonary contusion underneath and the pain. The pain leads to shallow breathing, which leads to atelectasis and pneumonia. So the treatment focus is now all about oxygen, fantastic analgesia-like epidurals, and aggressive physiotherapy. Ventilation is really reserved for respiratory failure.
Okay, we've covered the critical 6. Let's do a quick case study. A trauma patient arrives, multiple stab wounds to the left chest. They're hypotensive, tachycardic, distended neck veins. On the left side, breath sounds are absent and percussion is dull. Why does that word dull point more towards a massive hemothorax than a classic tension pneumothorax?
Because the word dull is the decider. A tension pneumothorax is trapped air. Air makes the chest hyper-resonant when you percuss it.
Like a drum.
Exactly. Dullness thinks fluid, blood. So given the vital signs and the absent breath sounds, you're dealing with a massive hemothorax until proven otherwise. It's a critical distinction to make in that primary survey.
Okay, now for the second half of the deadly dozen. The 6 potentially life-threatening injuries usually found in the secondary survey.
Starting with thoracic aortic disruption, this is your classic high-speed deceleration injury, a fall from height, a car crash.
And the injury happens at a very specific spot.
Just distal to the left subclavian artery where it's fixed by the ligamentum arteriosum. The body stops, but the heart and aorta keep moving, and it shears right at that fixed point.
And the key clinical clues.
Asymmetrical blood pressure between the arms, or between the arms and legs. A widened mediastinum on the chest x-ray is the classic sign. But here's the critical insight. If that patient is profoundly hypotensive, the bleeding is usually not from the contained aortic disruption. It's from something else.
The ones with the complete disruption rarely even make it to the hospital.
Exactly. So while you're managing the aortic injury, controlling the blood pressure, planning for a stent, you have to keep looking for another source of bleeding.
Next, diaphragmatic injuries.
We know any penetrating injury below the 5th intercostal space is suspicious, but blunt trauma can cause a rupture, usually on the left side. Then the abdominal contents just herniate up into the chest.
And the diagnostic anchor for the learner.
Once you place a nasogastric tube, check the chest x-ray. If you see that NG tube curling up in the chest cavity, you've made your diagnosis.
And the absolute surgical rule for repair.
Any penetrating diaphragmatic injury must be repaired via the abdomen. You have to go in through the belly so you can thoroughly inspect for any associated bowel or stomach injuries that would be catastrophic if you missed them.
Okay, briefly, what about tracheobronchial injuries?
They're rare but dramatic. You'll see a massive continuous air leak from the chest drain, huge amounts of subcutaneous emphysema air under the skin, and the lung just won't re-expand. Requires very specific management.
And blunt myocardial injury.
Think about it in any blunt chest trauma patient who suddenly develops a new arrhythmia or ECG changes. They need close cardiac monitoring.
And esophageal injury.
High mortality if you miss it. Pain on swallowing, unexplained fever, maybe some air in the mediastinum. Needs urgent repair and extensive drainage.
Finally, pulmonary contusion. Just a bruise on the lung.
But it's the leading cause of hypoxemia after blunt trauma. And it's tricky because it often gets worse over the first 24 to 48 hours. The key teaching point here is that even though the lung is bruised, you must maintain normal fluid volume, normovolemia, to perfuse the rest of the body. Fluid restriction is not advised.
This exhaustive review brings us to the last desperate measure. Emergency department thoracotomy, or ADT.
Yeah, the decision to crack the chest in the ER is one of the hardest in surgery. It's a race against time. If the patient is deteriorating right there in front of you, waiting 5 minutes to get to an operating theater might be 5 minutes too long,
And the source provides very clear futility criteria.
which is vital. You reserve EDT for patients with penetrating injury who still show signs of life, some electrical activity. If they had blunt trauma with no signs of life at the scene, or CPR has been going on for more than, say, 15 minutes in a penetrating trauma patient, the chances of survival are basically zero.
The survival stats are just brutal.
They are. If the systolic blood pressure is below 40, survival is around 3%. The goals of EDT are immediate and limited: internal cardiac massage, direct control of bleeding from the heart or lung, and cross-clamping the aorta to save the brain and heart. It is purely a salvage procedure.
Okay, let's move down the torso into the abdomen. The challenge here changes completely. We go from air and pressure threats to a cavity full of potential hidden bleeders.
And as we said, blood isn't really an irritant in the abdomen, so huge amounts can accumulate without causing obvious pain or distension, and that leads to fatal delays.
Indecision is the enemy.
It is. The management has to be dictated by the patient's physiological status, and there's a really clear three-tiered triage system.
Let's define that triage because it determines whether you reach for an imaging modality or a scalpel.
Right. So if the patient is physiologically stable or normal, you have the luxury of time. You can get a full, detailed CT scan with contrast to make your plan.
Okay.
If they are non-compromised, so not fully stable but not actively crashing, your investigation has to be limited. An EFAST, maybe straight to angiography. But if they are compromised, unstable, hypotensive, not responding to fluids, all investigation stops. They go for immediate surgery, a laparotomy.
So investigations serve the physiological need, not the anatomical curiosity.
Perfectly put.
Let's talk about that hierarchy of investigations, starting with EFAST. What are its key limitations?
Well, it's rapid, it can detect free blood, but it's highly operator dependent, it's unreliable in obese patients, and it's terrible at looking at the retroperitoneum. And crucially, a negative EFAST does not rule out a significant solid organ injury if there's no free blood.
And we should still understand diagnostic peritoneal lavage, DPL.
We should. In resource-limited settings, it's still the standard. It gives you a simple yes-no answer. Is there blood or contamination in the belly? Aspiration of more than 10 mils of frank blood is a positive. It's about speed and certainty when you don't have a CT scanner.
But if the patient is stable, CT with IV contrast is the gold standard.
It's the gold standard. Superior detail of solid organs, it defines retroperitoneal injuries beautifully, and it helps you plan for things like embolization. The key is the patient has to be stable enough to get there and back.
Right. Let's turn to specific organ injury management anchors, starting with the liver, the most commonly injured solid organ.
Right. And when liver injuries do require surgery, and remember, many don't, the surgical approach is defined by the 4 Ps. This is a fantastic conceptual anchor for damage control in the liver.
So let's break down the 4 Ps. Why are they preferred over an immediate complex repair?
Because they're all about temporary control. So first, pressure. Simple bimanual compression of the liver to tamponade the bleeding. Second, the Pringle maneuver. You clamp the portal triad, which is the main inflow to the liver. It gives the surgeon a moment of calm to see what's going on.
Right.
Third is plug. Using sutures or special tubes to plug deep, penetrating holes. And fourth, and most critically in damage control, is pack.
Just packing the area with surgical sponges.
Exactly. You place large abdominal packs around the injury site to provide relentless pressure. Then you close temporarily and get the patient to the ICU to recover physiologically.
The source also gives us a vital vascular rule for the liver.
The liver is unique. It has a dual blood supply. So the hepatic artery can usually be tied off without killing the liver because it can survive on the portal vein's supply.
Oh, the portal vein.
The portal vein must be repaired or shunted. Tying off the portal vein is catastrophic. It causes immediate portal hypertension and has over 50% mortality.
Okay, moving to the spleen.
In children, isolated splenic injuries are almost always managed non-operatively. But in a compromised adult with multiple injuries, a splenectomy removing the spleen is often the safer, faster damage control option than a lengthy repair.
And the key post-splenectomy reminder.
They've lost a key part of their immune defense. They are at lifelong risk of overwhelming infection. They need a pneumococcal vaccination, usually 2 to 3 weeks after the surgery.
Yeah, for the really tough customers,
Yeah.
the pancreas and the duodenum.
Yeah, the retroperitoneal challenge. Their injuries are often silent, masked by other tissues. The text gives an incredibly strong instruction here.
What's that?
The complex Whipple's procedure should never be performed in the emergency setting. The mortality risk is astronomical in an unstable trauma patient. Simple packing and drainage is the damage control choice.
And what about small bowel and colon injuries?
Small bowel needs urgent repair or temporary control because of the huge risk of contamination and sepsis. You can do a clip and drop where you staple off the injured ends to contain the mess and come back later. Colon injuries often require a diverting colostomy if the patient is unstable.
Finally, let's revisit the retroperitoneum zones, the 3 zones where hematomas form, and the critical rule about when to open them.
Okay, zone 1 is central. This is where the aorta and vena cava live. These hematomas must always be explored, but only after you've secured vascular control.
Right.
Zone 2 is lateral renal, kidney injuries. You usually only explore these if they're expanding, pulsatile, or from a penetrating injury. Most are managed non-operatively.
And the most dangerous, zone 3, the pelvic zone.
This is the real danger zone, and the most important principle here is you do not open pelvic hematomas.
Why not?
Because they are almost impossible to control surgically. The intact retroperitoneal fascia is providing a tamponade effect. If you open that, you release the pressure, and you can cause immediate uncontrollable exsanguination. Management must be external: compression, packing, or embolization.
Which brings us to the pelvis itself. It represents a catastrophic level of force. Mortality rates are still around 40%.
Yeah, and most of that bleeding is venous, about 85%. But the arterial bleeds in an unstable patient are fast and unforgiving.
And the structure of the pelvis contributes to a terrifying phenomenon. The text calls it the chimney effect.
Right. When the pelvic ring is severely disrupted, that retroperitoneal compartment is no longer a contained space. The hematoma can track all the way up towards the mediastinum or down into the thigh. The patient basically can't tamponade their own bleed. They just bleed into this massive, unpressurized space.
Diagnosis starts with a clinical exam, and there is a crucial rule for every trainee.
There's absolutely no role for springing the pelvis. That old maneuver to test for stability, it just risks dislodging a clot and starting a massive hemorrhage.
So if you suspect an unstable fracture,
The immediate life-saving step is to apply a pelvic binder or just a simple sheet wrapped tightly around the greater trochanters. You are mechanically reducing the pelvic volume.
and once you have imaging, the tile classification helps you understand the stability.
It does. Type A fractures are stable. Type B are partially stable. It's an open book fracture. But the type C is the complete disaster, completely unstable. Both the front and the back are disrupted, allowing it to displace in any direction. This demands immediate, aggressive intervention.
And that intervention is the 3-pronged attack.
It's a great way to think about it. You have to attack both the bone and the vessels. So prong 1 is compression. That's your binder or sheet.
Right.
Prong 2 is packing and fixation. For the 85% of venous bleeding, you do extraperitoneal pelvic packing the space between the bone and peritoneum, and you apply an external fixation.
And prong 3.
Angioembolization. This targets the arterial bleeding that the packing can't control.
The need for speed and physiological restoration brings us to the ultimate strategic concept: damage control.
This is where the philosophy of physiology over anatomy is fully realized. Damage control is accepting imperfect surgery to save a life. The enemy you are fighting in a long operation is the deadly triad.
Hypothermia, acidosis, and coagulopathy.
And it's not just a list, it's a physiological feedback loop, a death spiral.
So how does damage control interrupt that spiral?
Well, a long surgery causes blood loss and heat loss, which is hypothermia. Hypothermia stops your clotting factors from working, which is coagulopathy. Poor perfusion and hypothermia create acidosis. Acidosis makes the clotting even worse.
That's a vicious cycle.
It is. So damage control surgery aims to stop the operation as soon as possible, often in 60 to 90 minutes, and get the patient to the ICU to be warmed up and biologically fixed.
And the initial operation has only 3 goals.
3 non-negotiable goals. 1, stop any active surgical bleeding. 2, control any contamination. 3, restore normal physiology.
And then you get out.
You get out. You pack them, you do a temporary closure, and you send them to the ICU for resuscitation. The definitive surgery only happens a day or 2 later when the patient is warm, clotting, and stable.
And that temporary closure itself is a key technique.
The vac pack or opposite sandwich, it's not just a lazy closure. It prevents the huge physiological insult of trying to close a swollen abdomen, and it manages the risk of abdominal compartment syndrome or ACS.
Let's just touch on the severity of ACS.
It's devastating. The raised pressure in the abdomen crushes the kidneys, causing renal failure. It squashes the vena cava, causing cardiovascular shock. It pushes up on the diaphragm, causing respiratory failure. If ACS is a risk, the abdomen must be left open.
This sets up our final check-in. You have an unstable patient with an open book pelvic fracture. You've applied a binder. An EFAST rules out any significant intra-abdominal bleeding, meaning the hemorrhage is primarily venous. What is the next specialized step to control this bleeding?
Okay, so the bleeding is venous, and it's contained in the retroperitoneum. The goal is external pressure. The correct next step is extraperitoneal pelvic packing and applying an external fixator. You are explicitly avoiding opening that retroperitoneal hematoma. You are respecting the rule for zone 3.
We have synthesized a huge amount of information today. We navigated the junctional zones, identified the subtle signs of shock, anchored the deadly dozen, and critically, we understood why damage control strategy dictates everything in the unstable trauma patient.
That shift from immediate anatomical repair to rapid physiological stabilization is the single most important lesson of this entire chapter. It's about being a trauma physician first and an anatomist second in those critical first few hours.
And that strategic imperative leaves us with our final provocative thought for you to consider. We've seen that in major trauma, the initial focus is purely on physiological survival, achieved through these radical abbreviated techniques like damage control. So the question for you to mull over is this: how does the necessity of achieving that immediate stability, which often results in open wounds and deferred repairs, how does that ethically and clinically balance against the desire for the quickest possible definitive anatomical repair, especially when you consider long-term outcomes like infection risk or hernia formation?
It's the core challenge of modern trauma care, isn't it? Saving the life now, but always planning for the life later.
A profound thought. We really encourage you to go back and revisit Chapter 29 of Baily and Love to deepen your understanding now that you're equipped with this conceptual framework. Until the next deep dive, stay curious.